Let's talk about my first day in the hospital. My face is really broken out. Don't look at that. Oh my God, there are so many systems I need like specific logins for. Like there's the general portal, something at home for like modules, something for like my timesheet, something for like inventory for ordering the drugs, something for like the big machine that pulls the drugs, another system for like unit dose packaging. There's another system for like IV compounded products, something for TPN, something for the machines that you pull the drugs out on the floors. There's another system for like little kits that you make with medications for like RSI and stuff. That's already like 10 systems. Microsoft Teams, GroupMe, there's a little app that you can get to talk to different providers. I had to get an Outlook email, Authenticator app. Y'all, I have so many emails in my inbox and so many modules. But anyway, first day was pretty good. Time really flew by. I'm like logging into all these different emails. We had like a team huddle. We had like a meeting where a resident gave a presentation on like basically inappropriate usage of TPNs. Apparently like less than half of the TPNs that have been ordered were not following Aspen guidelines, meaning it wasn't really indicated for that patient. Not good. That can be like an infection risk. It's expensive, a bunch of other stuff. Let me tell you this, the pharmacy technicians in the hospital, they are doing so much. They're doing the IV compounding. They're prepping the like unit dose package meds to fill like this big machine that has all the drugs, and they're bringing up stuff to the floors and putting them in the little machines up there. They're filling the little med kits. There's something called Tech Check Tech with that in the hospital, with that like when it doesn't involve controlled substances. They're doing like the drug ordering. They're doing so much. So the pharmacists get to do like a bunch of like clinical stuff. Amazing. So they're like verifying the orders, and then they have a bunch of different pharmacists in like the ED and the ICU and oncology. Had another little meeting that went over like treatment guidelines, like or protocols within the hospital. And then I also looked at the antibiogram, which is basically like susceptibility between different bacterias and like resistance patterns and whatever for the hospital. And then I went to a code meeting. This is one of the things that I didn't really learn in school, like what to do in a code blue. Medication wise, we did like a simulation in lab of like compounding everything, but we didn't learn like the back end ACLS guidelines. So we had an emergency medicine pharmacist like talk about all the medications and how to dilute them, how to like what to push and what the doses are, and when you give them, what the maxes are, what to give in certain conditions. So we learned about like epinephrine with PEA, like a MEG Q4. We learned about dextrose 50%. So if patient has hypokalemia, calcium gluconate for cardiac membrane stabilization, and then dextrose 50, and then insulin, maybe bicarb if they're acidotic. Talking about atropine and bradycardia, magnesium for torsades and VFib and VTAC. Talked about diluting it in dextrose, or sometimes they have to do a push and a flush. Talked about amiodarone and like VFib resistant to shocks. Talked about a 0.22 micron filter with that due to thrombophlebitis. He mentioned something about how bicarb might not actually help with morbidity and mortality in situations. So I'm gonna have to like look into the literature with that one. Talked about adenosine with stable narrow-complex monomorphic SVT. I'm gonna have to look into that. And they talked about norepinephrine as pressure support once the code is over. He mentioned something about how it was like going on and off back order, so they had to make like a dirty drip at one point. And then we talked a little bit about like norepi if the heart rate is elevated and the blood pressure is low, and then epinephrine if the heart rate and blood pressure are both low. We briefly talked about flumazenil, which is the benzodiazepine reversal. We don't really use it because it can cause seizures. They usually like to do supportive care and intubation. And then they talked about 0.4 milligrams naloxone versus 2 milligrams naloxone, and situations you would use like one or the other. Dopamine's not used much. There's like a bunch of stuff in this code cart that I'm like not used to since I've been working in like community for a while. So there's a bunch of new things like pressure bags, 3-way stopcock, suction canisters, chest tubes, central line kit. I'm a little nervous with all of this, but I know I'm gonna learn like once I'm like there for a while. It was really interesting going over the RSI kits. It stands for rapid sequence intubation. So there's a etomidate in it, which is a general anesthetic. And then we had 2 paralytics, acetylcholine and rocuronium. So I said, make sure if we're using rocuronium, we gotta make sure that we have an anesthetic on like board after the etomidate wears off. You don't wanna be paralyzed without an anesthetic. Then he talked about not wanting to use like acetylcholine if you see like peak T waves, because the patient could have hyperkalemia. So I said not to use it with like burns, trauma, and dialysis. So propofol if they're hemodynamically stable, or fentanyl or Versed. Lots of interesting stuff. I'm gonna have to find time to like put all of this information down in like a study guide and like look over it in my free time. And then I'm also gonna review the ACLS guidelines. But yeah, interesting that I get to take all of you guys with me on this inpatient hospital journey.